Good morning and welcome. My name is Jane Lewis. I am chair of the Hospice Palliative Care Society of Cape Breton County. And on behalf of our society and our partners here at Cape Breton University, I am delighted to welcome you to this morning's event, which is going to feature Dr. Harvey Max Chochinov. Before I introduce Dr. Chochinov, though, I want to tell you a little bit about who our society is and why we are here today. Our society, the Hospice Palliative Care Society of Cape Breton, is a nonprofit volunteer entity that has been promoting and supporting preeminent end-of-life care for almost 40 years. We work closely with our partners from Nova Scotia Health, who provide exemplary service in many, many settings across our community. And that many settings is an important thing to keep in mind. I'm sure some of you are familiar with the fact that there is a 9-bed palliative care unit on the 4th floor of the regional hospital. That's on Kala. And many of you probably know that we opened a new hospice residence a few years ago that is on Charles Herney Atwee Way, which is the road from the regional over towards Membertou. There's a beautiful building there, kind of tucked into the woods if you haven't seen it. That's a 10-bed residence. But in addition to those beds, at any given time in our community, we have 200 to 250 patients in palliative care service. So patients are receiving that care in their homes, in continuing care units, in some of the smaller hospitals. Really, our goal is to provide care where patients need that care, whatever is right for their setting. It's wonderful to be at CBU here today and to see so many students here, particularly because we want you to learn about this field of medicine and invite some of you to think about your careers in this area. Now, we're partnered with CBU on this event for a couple of reasons, not the least of which is that we've been partnered with CBU for a really long time. End-of-life care is really part of a community wellness agenda. A comprehensive wellness plan in a community includes supporting people from birth to death and all the places in between. And we're especially happy to be here with CBU this fall because we want to congratulate them and celebrate with them the opening of the Cape Breton Medical Campus, which we believe is going to really enhance all areas of healthcare in Cape Breton. Now, I'm pretty sure this is Shut Up Jane Lewis time and introduce Dr. Chochinov, so I'm going to get on to that. And we really are delighted to have him with us. He will be able, we think, time allowed, to take a few questions at the end. Dr. Harvey Max Chochinov is a distinguished professor of psychiatry at the University of Manitoba and a senior scientist at the Cancer Care Manitoba Research Institute. His research offers new insights on palliative care and person-centered care. He has more than 350 career publications and nearly 30,000 citations of those publications around the world. He has addressed topics such as depression, quality of care at end of life, suicide, vulnerability, spirituality, and existential distress towards end of life. You know, I've had the opportunity to talk to Dr. Chochinov a few times as we prepared for this event. And several times in those conversations, he would remind me, you know, my areas of expertise don't just have to do with palliative care and end-of-life care. This is about compassionate, person-centered care at all parts of the medical system. Dr. Chochinov has also led a large program of research on dignity in the healthcare setting, which includes the development and the study of dignity therapy. He is co-author of the Handbook of Psychiatry and Palliative Medicine, Oxford University Press. His latest book is entitled Dignity in Care, The Human Side of Medicine, published by Oxford University, and his new book will be released in November. He has been the recipient of numerous honors and awards, including the Canadian Medical Association's highest recognition, the FNG Star Award. He is a recipient of the Order of Manitoba and is an officer of the Order of Canada. In 2020, he was inducted into the Canadian Medical Hall of Fame, Please help us give a warm Cape Breton welcome to Dr. Harvey Max Chochinov.
Thanks so much, everyone, and it's really a privilege to be here. Last night when I went to my hotel room, I looked at my CV to check when the last time I spoke in Sydney. It turns out it was 2003. So I'm thinking that if this talk goes over well, perhaps we'll make a tradition every 22 years that Chochinov will be invited back to Sydney to give a talk. I hope it's not that long. So I'm here to talk to you a little bit about my career in medicine, in palliative care. And contrary to rumor, I haven't always been a psychiatrist. Haven't always been a palliative care researcher. And in fact, when I started out on my path, I thought music was going to be the direction my life would go. You see me here. Oh, and the other thing I'll say is you can notice that a career in medicine is not good for one's hairline. And I'm the fellow, if anyone didn't know, the fellow standing in the middle at the back of the room. And I had aspirations that, maybe music would be a reasonable path to follow. As it turns out, this is the only gig I have. I have a grandson, and he seems to, I can play Baby Beluga like no one's business. And he seems to enjoy that. So, all of this is to say that, I know many in this room are students and you're just starting down this kind of a pathway in your careers. You don't know where it's going to lead, and be open to opportunities and stay curious. It's an extraordinary pathway you've chosen. Mentors are important. And, one of my mentors, and certainly influences, really a global influence in the area of palliative care, is this woman named Dame Cicely Saunders. Dame Cicely Saunders is the founder of the modern hospice movement. Dame Cicely is to palliative care what Mick Jagger is to rock and roll. Seriously. This photograph was taken the very first time that I visited Dame Cicely at St. Christopher's Hospice. If anybody is wondering why we're looking happy, it's that the only thing Dame Cicely asked me when I went into her office, this was her liquor cabinet back here, and she asked me, would you care for a sherry? It was 10 o'clock in the morning, and I was about to go and give a lecture to everybody at King's College. But when Dame Cicely Saunders asks you, would you like a sherry? There's only one answer. And the answer is yes. And those are our empty sherry glasses you see right in front of us. So more recently, I was invited back to give a lecture at Cicely Saunders Institute, now named after Dame Cicely, who died a number of years ago. And after that talk, I was also invited to give grand rounds at Oxford University. And here you see me standing with another mentor, influential role model. This is Robert Twycross. And while the name may mean nothing to you, Robert Twycross conducted some of the early studies on the use of opioids for cancer pain. So the way we treat patients today were very much influenced by the studies conducted by Robert Twycross, who happened to also be one of the first people that was hired by Dame Cicely when she established St. Christopher's. The other mentor that we need to acknowledge, and I want to acknowledge, is Balfour Mount, Dr. Balfour Mount. If any of you were listening to CBC Radio this morning, there was a whole show that was dedicated to Dr. Mount, who died 2 weeks ago, I think it was. He was considered the father of palliative care and coined the term palliative care. 50 years ago, he heard about one Dr. Saunders in the UK, decided that he was going to go over there, find out what she was up to, as he did, and returned to establish what turned out to be this kind of global movement. Having established the palliative care service at the Royal Vic, and died on a ward named in his honor, the Balfour Mount Palliative Care Unit at the Royal Victoria Hospital. So these people are really kind of heroes when it comes to understanding the whole issue of patient suffering. And this particular painting is by Robert Pope, who hails from Nova Scotia. Many of you may know of his name. Certainly in palliative care circles, all of us know about the work of Robert Pope, and he created these magnificent images. I put up this image of his because, I mean, to me, when you look at it, it's somebody who's precariously teetering on the water's surface. And it makes you think about, what keeps somebody buoyant? What threatens to pull someone under? And if we're going to understand, the human experience of confronting illness, whether it's at end of life or any time of life, we need to understand those various forces. And that's what my work has tried to illustrate, has tried to illuminate over the course of the last 35 plus years. So it all began for me when I happened upon this paper by a colleague of mine, Jim Brown, who was a psychiatrist, as it happens, working in Winnipeg. And he broached what was really, for me, I mean, in some ways it's an obvious question, but yet it is a question that had never been asked before. And that is, at least in an empirical way, is it normal for terminally ill patients to desire death? Now remember, this is at least 30 years predating Carter versus Canada. So he was not studying medical assistance in dying. He just wanted to know, so if you have a bad illness, is it normal for there to come times when people might covet an earlier demise? And he interviewed a number of patients at St. Boniface Hospital, which is, where our first palliative care unit was established. No, maybe I'll save that comment to myself. Sometimes I have to control my sense of humor. I think, is that going to go over well, or is that's? I'll share it with with President Dingwall in private, and he can tell me whether or not that would have been appropriate or not. So he studied these patients who were all in a palliative care unit, and he reported that of those who had a genuine desire to die, all of them seemed to be suffering from a concurrent depression, which was fascinating, but it left me wondering, can it be the case that a wish to no longer go on living is a reflection of a psychiatric condition? Period. That there are no other explanations. And we thought there must be something more to it than that. And so we began conducting much larger studies and looking at a variety of sources of things that might influence the wish for somebody to continue living or not. And eventually, and these were like in the mid-1990s, we published this paper on desire for death in the terminally ill. This was in the American Journal of Psychiatry. And what we discovered, and again, the numbers aren't important, but it's the overarching message that is, what we discovered is that if you're going to understand something as complex as, is life worth living? Do I want to go on? You need to understand it from a multitude of vantage points. And so by that, I mean, there are physical things that may influence whether or not life is feeling okay for you. We discovered in this cohort of 200 patients in palliative care, 80% of them had pain of moderate severity or greater. You need to be thinking about kind of the environment, that is supporting, the context in which their illness is taking place. And indeed, we discovered that those who desired an early death had the perception that family was less available, was less supportive. And you also need to understand kind of the internal or psychological or spiritual landscape, what's going on inside of someone's head, and their psychological makeup. And indeed, we discovered that about 70% of patients who desire death met criteria for syndromal depression versus less than 10% amongst those who did not endorse a desire to die. By the way, if some of this feels like it's going by quickly, all of my articles are open access, so you can go to any search engine like PubMed or dignityandcare.ca, and you can kind of dig deeper and kind of get a more fulsome sense of what the research is about and what we've shown. This was a really interesting study that we did because what we realized is that if you're going to study, this idea of do people want to go on living, The one thing you notice when you're working in palliative care, and again, it probably applies to most of medicine, but very certainly in palliative care, is that things are changing. The situation you find this morning may be a very different situation than you find this afternoon or this evening. So we did what we called a will to live study. Twice daily, we had patients fill out a measure, the Edmonton Symptom Assessment Scale, for those who are familiar with it and work in palliative care, a very common instrument developed by a colleague of mine, Eduardo Barrera, who was working in Edmonton, Canada at the time. And we had patients fill out that instrument, including a visual analog for will to live. Anything that scores high on the ESS is indicative of distress. And what's interesting is this is the data that I've parsed out from the couple of hundred people that took part in the study. This is one data set from an 80-year-old woman with end-stage colorectal cancer. You can see that when she first came in yellow, this is her will to live. So it starts off poor, it immediately improves, it stays steady until she is approaching end of life. And then it becomes more unsteady or less stably reported. And once she is no longer competent, we stop measuring data because of its lack of reliability. Superimposed on this, we could also then look at, well, what pain was she subjectively reporting? And what you can see is this incredible, if we use a dance metaphor, this is a tango. Pain and will to live seem to be in this very intimate dance one with the other. We can't talk about cause and effect, but we can say, maybe as we improve her pain, her will to live improves. Or when we admit her into a palliative care facility or a hospice facility where all of her needs are being met, she's not in as much pain. Her pain is mitigated in a positive way. The interesting and important thing is to remember that even though, and this is certainly very true if you're early in your medical career, to teach medicine and nursing, and we tend to silo things, so we tend to think about the people who are the pain specialists and the neurologists and the nephrologists and the pathologists, and all of this takes place within the entity of whole persons. And the fact is that when you have an influence in one of those areas, it has ripple effects across the entirety of who that individual is. So here's the evidence. Treating pain has very tangible and measurable spiritual outcomes, as tangible as whether I want to go on living or not. So eventually, we turned our attention to a constituency where assisted dying, medical aid in dying, euthanasia, or assisted suicide, as it was termed in Dutch literature, where this was no longer something hypothetical, but this was going on in real time. The reason we looked at that jurisdiction is we wanted to understand the psychology. What is it that brings people, not to the hypothetical decision, but actually seeking out a hastened death? And so there was this study that was commissioned by the Dutch government. They were interested in looking at MDEL, medical decisions to end life. And they reported that about 4% of Dutch patients were dying as a result of euthanasia, which is a lethal injection, as opposed to a much smaller portion, assisted suicide, which is giving a person a medication that they can use at a time of their own choosing. All of that was interesting, but more interesting was the question, why? Vandermeer went back to the death record, noted the physician who was indicated on that death record, and interviewed them. And lo and behold, according to these Dutch physicians, the reason their patient had sought out a hastened death, more so than anything else, was because of a lost sense of dignity. It was the first time that dignity had ever been on my radar, or something that might be interesting or worth looking at, but said to ourselves, like, if dignity is worth dying for, then it's worth studying. And so we began to study it, and indeed started to introduce what are really the first empirical studies of dignity in the terminally ill. This is, again, a cohort of just over 200 patients, and what you can see is that in half of them, loss of dignity was not an issue, which means that in the rest of them, I mean, at least 1 out of every 2 patients that we are seeing say that, dignity is an issue. There are times when dignity feels under assault. And for a smaller minority, I think it was about 7%, they said, my dignity is broken. My dignity is fractured. And so we began to look at, well, what are the things that can influence sense of dignity? And we looked at every variable we could think of, whether pain, anxiety, nausea, social support, just looked at everything that we thought might have an influence. The thing that came out as most predictive of dignity turned out to be something that I really hadn't expected or anticipated. It turned out to be appearance, and specifically how people perceive themselves to be seen by others. I'll state it a couple of more times because it's a bit of a mouthful. But as well, it was an epiphany. Because I had always thought about good palliative care being, the things that we do to patients or with patients and their families. And here the evidence was saying is that if you're going to influence something as profound as human dignity, we need to think about what's going on between your ears, your attitude, your outlook, you meaning the healthcare provider. And so I published this separate article in the Journal of Clinical Oncology, called it Dignity in the Eye of the Beholder. And even though it's based on evidence, what I say in the article metaphorically is that patients are looking for a reflection in the eye of the healthcare provider that will be affirming of their sense of dignity, of their sense of personhood. And then, as it happens, online I discovered this incredible etching by M.C. Escher, a famous Dutch graphic artist. And it's a self-portrait. And so what you can see is this is Escher in his apartment. He's surrounded by his belongings, his photographs, his pictures, his books. In other words, the reflection in the eye of the beholder is an affirmation. He is being seen for the totality of who he is. And why kind of go on about this? It's because the essence of suffering in healthcare is when people don't see an affirming reflection. And this isn't just about palliative care, this is about all of care. If you look in the eye of the healthcare provider metaphorically and see a problem checklist only, a differential diagnosis only, a treatment plan only, at the exclusion of that affirmation, then you suffer from what I've described as patienthood eclipsing personhood. And what we know is that there are famous writings by people, for example, like Eric Cassell, was a wonderful American internist who wrote about the nature of suffering and said that suffering happens when persons feel under assault or under threat of disintegration. So we need to be mindful of our gaze, the way we see people. It's going to influence their encounters in ways, and there is no neutral position. If you go in the room, if you're with a patient and you fail to provide that affirmation, that affects your experience. And it's something that everyone in this room, any of us who have been a patient know what that feels like. The great irony, by the way, is we've all trained and we're all training to be healthcare providers so we can look after patients. Nobody wants to be seen as just a patient because patient is a generic designation. It's based on some body part or organ not behaving well. Nobody wants to be seen as the embodiment, of a misbehaving organ. It's just not how we see ourselves. People want to be seen as the entirety of who they are, in addition to whatever brings them to medical attention. This is yet another study that we did on trying to dig down into what is dignity about. People often say, well, after all these years, so what does it mean? And what I say is, well, when I've asked patients what it means, these are the things that they say will influence my sense of dignity. The details are less important than kind of this overarching message, and that is kind of this multiple perspectives. You need to understand what the illness is doing, because the illness might cause some fallout that is going to undermine sense of dignity. You need to understand the environment in which it's taking place. We've called this the social dignity inventory. So things like privacy, social support. By the way, I'll just stop on care tenor. this gets back to the tone of care. You know, what patients sense, the vibe, if you will, when you walk into that room with a human being. Do they sense that they're just a patient? Do they feel that affirmation? Or do they sense that, you know, they're in the presence of somebody who's distracted and really focused? I'll give you a little anecdote. My father's 95. I go with him to some medical appointments. There are some physicians, I think this is not an exaggeration. There are some physicians who I don't think could identify him from a lineup because they are exclusively looking at their computer screen the entire time they're with him, typing in the various notes. So tone of care makes a difference. And then finally, what we call this dignity-conserving repertoire, it's really about the psychological landscape. You know, things like, you know, do you continue to feel a sense of self, preservation of roles, and so on and so forth. Again, it's quite detailed and the paper is available for you. So all of this is to say, the way you see people matters. You know, your gaze matters, your lens, all of what shapes your lens, those things are going to change your perception, and your perception is going to change the way a clinical encounter unfolds and what people feel. Years ago, I published an article that tried to say, there need to be some core efficiencies when it comes to healthcare, when it comes to the human dimensions of healthcare. You know, in critical care, I mean, all of us say that. I mean, if you come to the side of somebody who's unconscious, all of us are responsible for the ABCs of critical care: airway, breathing, circulation. And if I, as a psychiatrist, you know, God forbid, President Dingwall is unconscious and I go up to him, hold his hand as he takes his final breath and say, I'm giving him professional empathy, but I don't bother with the ABCs of critical care, you'd say, that is ridiculous. You know, that is really trying to absolve yourself of your, by the way, that was a very funny line and no one even, but maybe it's Winnipeg humor. What can I say? But when it comes to the humanities of care, we say, trust your gut, you know, be a kind person. And not everybody has those skills. So what are the ABCDs of dignity conserving care? Well, they're saying, if you're going to be in healthcare, here's what you need to do. The A is for attitude. I've already shown you evidence. Your attitude makes a difference. This is showing various things that are affiliated with sense of dignity in a cohort of patients with less than 6-month life expectancy. And you can see in ascending order the things that might undermine their sense of dignity. Don't worry about the numbers, but look at this. When you look at the things that are most highly endorsed by these patients, what they say is, you know, feeling a burden to others. In other words, feeling like I serve no purpose. And the flip side of that is, I don't think I'm deserving of honor, respect, or esteem. Where does that come from? It comes from you. You know, if patients can't contain it, they need it affirmed. So your attitude makes a huge difference. B is for behavior. You know, do you sit, do you stand, do you meet someone's gaze, do you not meet someone's gaze? All kinds of behaviors that don't necessarily take a lot of time that can make a difference between feeling that somebody is in the presence of a physician who is present, cares, or somebody, again, who is more distracted and not necessarily seeing the entirety of who's sitting with them or who's in that bed. So this is a cool study. I didn't do it, but this is a randomized, in case anybody is thinking, well, really, you're saying sitting, these don't sound like very empirically driven interventions to my mind. So here is a randomized controlled trial of sitting versus standing. These folks did this in orthopedic surgery setting. So the orthopedic surgeon has done their thing. They're coming to the first post-op visit. There's a chit in the door that they have to take and either randomly assigned to sitting or standing. What happens when, and then the conversation takes place exactly as usual. So they've changed nothing else in the physician's usual post-op first visit routine. What happens when they're randomized to sitting? The perception of the amount of time is magnified by 5-fold. So even though the actual visit was only a little more than a minute or so, The actual perceived time that they were there is magnified fivefold, and the level of satisfaction is 95%. Same group of physicians now randomized to standing, you don't get the same time distortion, and the level of satisfaction is somewhere between 45 to 60%. It matters. It gives the message, for at least this moment in time, I'm here. The C of dignity conserving care is about compassion. We could have a whole lecture about compassion, but in essence, compassion is about understanding the suffering of another person. And I underline person. You can't be attentive to suffering if you don't know at least something about the person. And the attempt to try and mitigate that suffering. This is a colleague of mine. He died far too young. His name is Stuart Farber. He was a palliative care doctor in Washington State. And he talked about, I'll share his words. He published this in the Journal of Pain and Symptom Management. He said, with rare exceptions, the clinicians who treated me have good hearts, care deeply, but possess little or no knowledge of my thread. And my thread is really the metaphor that he used to describe, the essence of who I am. In other words, you don't need to understand the entirety of my life. No one is asking you to sit down and be in a position to write a fulsome biography. But knowing the essence, what kind of makes you tick. And he finishes this particular paragraph by saying, without knowing my thread, it's impossible for a clinician to provide respectful care. So, and by the way, we always give kind of lip service to this idea of, we're all person-centered focused and we do person-centered care. And I say, okay, that's well and good, but you can't do person-centered care in the absence of knowing at least something, the thread of who that person is. The D is for dialogue, conversations that acknowledge who is this human being. And we have tried to introduce various different ways of introducing, personhood, placing personhood on your clinical radar. We introduced something called the patient dignity question, which basically reads, what should I know about you as a person to help me take the best care of you that I can? I mean, it seems, almost ridiculous that one would try and study such a thing, but the protocol works this way. We go to the bedside of that individual. We say, we know a lot about the things that are in your chart, so we know a lot about, the medical ailments that brought you our way. But we really don't know, very little about who you are, as a person or as a human being. This question is meant to be the basis of a short conversation, 5, 10, at most 15 minutes. And it's focused on trying to elicit the thread. We then go off and we summarize what we've heard into 2-3 paragraphs. I mean, we could write more, but it needs to be succinct so that somebody will take the time to read it. We then go back to the bedside to do 3 things. Read it to the patient, allow them to edit it in any way that they would like. And then finally, and this is the litmus test, do we have permission to place this on your chart? We've now done studies with hundreds of patients. In the literature today, there are thousands of patients who have been studied where this approach has been applied. I've never heard an instance where a patient said, no, the way that I think I want people to see me, I don't want you putting that on my chart. Everybody says, yes, this is how I want you to see me. And by the way, it can also be done by proxy. If the patient is no longer in a position to do it themselves, families are very adept at being able to respond to this and provide information to say, this is who you're looking after. This is my loved one. An example, this was an 82-year-old woman with colorectal cancer, and this is a paragraph from her patient dignity question, or PDQ. Mrs. F says that because of the residential school, she always had a hard time trusting people. She, in fact, moved 82 times so as not to let anyone get too close to her. And while this has gotten better over time, she still struggles with being able to trust people. She wants to, but it's hard for her. She sometimes worries that she won't be told the whole truth or that people will see her as not being deserving of the whole truth. She also told me, by the way, that she was afraid of people who wore white coats. Interesting. considering that all of us walk into a room wearing a white coat, or most of us. She approaches people being she appreciates people being friendly towards her, but is frightened of authority figures. Authority scares me, but I'm not as bad as I used to be. So what I ask myself and what I ask you is, how is it even conceivable that we could look after this person in the absence of knowing something that is just so profound and fundamental? I mean, I would say that, you might, whatever you're doing in delivering care, you can't be applying person-centered care in the absence of knowing her threat. And this is just data that we have to show that, and these are really rounding errors, it's accurate. Everybody wants it on their chart. And patients say, I think this is important information for my healthcare team to know. And I think this could kind of change the way people look after me. And when we ask healthcare providers who's actually read these things, well, not only do they report heightened job satisfaction, which is a whole other conversation that we may or may not have time to get into, but in 90% of instances, they say, I learned something about the person that I didn't know before, which again is phenomenal. These are people that are looking after, and this short conversation, and again, this isn't hours of, putting someone on the couch, which, is sort of my line of work. This is a 10, at max, 15-minute conversation, just figuring out, so who are you? Or, how would you like to be seen as a person? When people walk into this room, what is it you would want them to know about the person they're looking after? And even though this is in palliative care, this is where we conducted it, where people are sort of wired for compassion, between 45 and 65% of instances, people reported a heightened sense of connectedness, of empathy, of respect. And this approach is now kind of, taking hold worldwide. This is a graphic that I put together with at least the first 20 translations of the PDQ that I'm aware of. Now, I've been talking a lot about the healthcare provider gaze. And I think it's important for us to ask ourselves, well, what shapes our gaze? I mean, if our lens is so important, maybe we need to think about our lens and, how that sort of works. And intuitively, most of us, when we are at the bedside of a person, or clinically, or even, not even in medicine, intuitively, when you're trying to figure out what somebody else might want or need, you use yourself as kind of a barometer for what might work, what might be needed in this circumstance. The so-called golden rule. I'll do for you what I think I would do for myself or a loved one. Good starting point. Let me tell you about a dear colleague of mine. Years ago, when the government was considering legislation for medical assistance in dying after the Carter Supreme Court decision, I was asked by the government of the day to chair a committee that would really do an environmental scan. So around the world, what are the practices, what is known, and this was meant to inform the government, in terms of how they might proceed without, giving them a direction as to what legislation they would land on. One of the people on that committee was Catherine Frazee, who you see in the front row. Catherine has spinal muscular atrophy type 2, and certainly is encumbered by many physical disabilities. She also has a brain of an Olympian. She's an extraordinary scholar and one of the most amazing human beings that it's been my privilege to work with. And here's what Catherine wrote that I think is very telling. Having to wear diapers and drooling are highly stigmatized departures from what is expected of adult bodies. Those of us who deviate from these norms experience social shame and stigma that erodes resilience and increases vulnerability. The more deeply these stigmatized accounts are embedded in our discourse and social policy, the more deeply virulent social prejudice takes hold within our culture. And then she closes by saying, what assurance can we offer that the physician who treats these adults at end of life will not stand at their bedside with horror or revulsion in his heart? In other words, she's saying, how am I going to be seen when I step into a healthcare setting, or even perhaps more telling, how might I not be seen? And that really is the point, because our perceptions are shaped in ways that we can't necessarily or aren't necessarily in touch with. So I've talked about the golden rule and the fact that the golden rule, it imposes this external standard. But what about a different standard? In this article, I talk about an instance where, and this is a true story of a gentleman who had a bad head and neck cancer. There's an encounter with his own medical oncologist who says, look, I'm not saying now, but at some point, things really might turn ugly. They might not go well. And at that point in time, you might want to consider medical assistance in dying. And what the article does is it tries to unravel, well, what might have been going on in the mind of a healthcare provider? And might have, in this instance, he, being offering advice that would help him avert a future that he personally would find untenable. So in other words, he's using his own lens to try and infer what this patient might want. And in fact, that is not at all what the patient wanted. So I wrote about what I have called now the platinum rule, doing unto patients as they would want done unto themselves, which isn't to say that everybody gets all things at all times, but it says that the lens that is critically important is not just our own, but the lens of the patient. And this means we always have to consider the patient's perspective, and it'll help us recognize and confront our own personal biases. And I think it's an important element when it comes to thinking about, EDI, equity, diversity, inclusiveness. And it raises the bar on certain on patient-centered care. The second article actually that I wrote about this was an article called "Seeing Ellen in the Platinum Rule." This was published in JAMA Neurology. This is a photograph of my late sister Ellen. Ellen was born with cerebral palsy. She died about 10 years ago at the age of 55. And she had all of these sequelae that one would imagine physically, psychologically went with a condition like cerebral palsy. A few years before she died, and including kyphosis, scoliosis, terrible lung capacity, she couldn't blow out birthday candles if her life depended on it. And the rest of us would help her with that, of course. So several years before she died, she finds herself, we find Ellen with her in intensive care, in an intensive care unit. And she's on the brink of the decision needing to be made whether or not she will be intubated. And the intensivist is kind of wandering around the unit and trying to figure out what to do. He comes up to me. I mean, I've worked with this gentleman at various times, working in the hospital. And he comes up to me and he asks me the only question that he was intending to ask about personhood. So he came up to me and says, so by the way, does she read magazines? And I looked at him and I thought, my sister's really sick here. What nonsense is it? Why are you asking me if she reads magazines? Until I realized the subtext. And the subtext was, he could see her bent spine and he could see her falling blood gases, but he couldn't see Ellen. He didn't understand who this person was, that she was loved and loving and had a complicated but very rich life. So I said, well, yes, she does read magazines, but only when she's in between novels. In other words, understand the patient's lens. So the summary of all of this is that, in medicine, objectively, we are very involved in transactional elements of medicine. As students, we're trying to understand the physiology and the pathophysiology. As clinicians, we're trying to understand a diagnosis. We're trying to understand a problem checklist. We're trying to understand treatment options. But at the center of it all, always has and always will remain a person needing to be seen. So some of you may recognize this gentleman that I'm sitting next to. This is, of course, Mark Carney, now Prime Minister Mark Carney. And this was at an Order of Canada ceremony. And I put this up because, again, it's to say, you don't know where life is going to take you to. You don't know where this path is going to lead. Nor, by the way, do you know where it's going to lead for the person sitting next to you. This photograph was also published after this ceremony. These, for those of you who don't know, these are members of the Blue Rodeo Band, a Canadian famous rock band. And my friend said to me that, they think the reason that everybody is laughing is because Mark Carney has just said to Jim Cuddy that Harvey would like to join your band. So with that, that's who I am. That's how to get hold of me. And again, it's been a privilege to have your time here together this morning. I'm happy to take questions. Does this mean that maybe less than 22 years? Yeah. So, questions, and is there somebody to moderate that, or do you just want me to do that, Cord? Okay. So questions. Good. I was going to say, if nobody asked the question, I was going to remind you that I'm a psychiatrist and I'm comfortable with silences. So yes, we have a question. I'm going to step down here so that I can see.
In nursing, we follow the framework of, the philosophy of quarantine. And when I looked a little bit into what you had written, it was mirroring respect and compassion and seeing the person beyond the illness. Now, I was wondering if there were any nursing philosophies that influenced you or those that you wrote in your research, or if it's just your clinical research and, experience. And also, second question about the PDQ. When we admit patients and we're asking these questions, is it okay to amend it as they continue their journey through health? Thank you.
And when you say amend it, we need to revisit
Not
it.
amend, but continue to revisit it because at the end of the day, they're on a journey.
Good.
Thank you.
Sure. So the first question was about influences. And, certainly people like, you mentioned Florence Nightingale. I also mentioned Dame Cicely Saunders. What's interesting about Dame Saunders in terms of her perspective is she trained, I think it was either initially as a nurse and then became a social worker, or vice versa, and then went on to medicine. So it's kind of this kind of eclectic approach that she said was necessary. And again, I've said a number of times, you need those kind of multiple vantage points in order to understand, the whole person. I can also say, by the way, over the course of my career, I have worked very closely with nurses and nursing colleagues, including nursing research colleagues. One of my really colleagues and mentors was a woman named Linda Christensen, who is an amazing palliative care researcher, Canadian. Also developed some wonderful measures of family satisfaction, and really was one of the people who helped turn me from having started off this life as a clinician and introduced me to research. Aside from that, I mean, where I've been informed has been by the empirical work. So, I mean, even though it kind of at times may sound like I'm sort of giving you a sermon and pontificating, the fact is, I mean, I don't know anything about this that I haven't learned from my patients. And I haven't died yet, not even once. So the things that I know about this are from people who are close to that experience. Although, again, I would remind you that palliative care doesn't have a monopoly on dignity, kindness, personhood. Those things matter from cradle to grave. The second question was about the patient dignity question, and is it okay to revisit it? You might want to, there's an article, I think I put it in that handout so that you may see the URL. It's called Revisiting the Patient Dignity Inventory, and it talks a little bit about that. What I would say is that, I mean, we need to understand that although medicine oftentimes becomes very focused on the transactional stuff, the pills, the surgery, the radiation, all of the stuff that we do to patients, the relational aspect is critical. So it needs to always be on our radar. Because if we fail to do that, what ends up happening is patients aren't as trusting, they're not going to be as disclosing, more likely to be discordance when it comes to goals of care. And as well, people get into trouble. You sacrifice reputational capital, yours and your institution. And if there's anybody here who works in human resources in a hospital setting, they'll tell you that, 95% of their caseload is because people are complaining because of a communication breakdown. They didn't feel treated right. I mean, 5% medical misadventures, mistakes happen, but the rest of it has to do with, these fundamentally human issues.
More questions?
Yep, at the back.
Question about the word dignity.
Yes.
And you use it a lot. You also wrote a paper about caring for patients and how do they necessarily feel that, reminding patients that matter. In the olden days, when the church was sort of involved in healthcare and the nuns, we had this kind of vision that the person was made in the image and likeness of God. As society has shifted, that is kind of old-fashioned, passé mindset. How does healthcare in a secular framework view the human person? Is dignity based on something other than being made in the image and likeness of God? So what defines dignity and what's it objectively based on? Why should we care?
Okay, well, is there a hard question that some people... Okay. So for those of you who may not have heard, what does dignity mean? What about the spiritual antecedents and basis of dignity? I mean, how do we understand that, especially in a secular society? I guess I would say that, when you think about medicine and, the pathway medicine has followed over the millennia, over the centuries, let's say, at one time, all we had, in large measure, was presence, was the relational. I mean, there weren't necessarily a whole lot of things we had available that were very effective. And so at that time, I mean, the essence of being with a patient, was about presence and relationships and spiritual dimensions of care. Over time, we've come to learn stuff, and it's pretty interesting stuff that allows us to actually change the course of illness, to mitigate the experience of patients in very tangible ways medically. And so the pendulum swings in the opposite directions, where we become overwhelmed and then even seduced by the transactional. I mean, I'll be talking about this in another talk, I think, later on today, where the medical paradigm is about we examine somebody, we diagnose what's going on with them, and then we fix it. That's the traditional medical paradigm. What all of us who've lived long enough or worked in medicine long enough know is that not everything lends itself to that. There are things that we encounter in life that just can't be readily fixed. But that doesn't mean that there's not a role for us to be healers. And part of being a healer is understanding being presence. So the other thing that comes to mind is, as I'm listening to you, I'm reminded, and I fully admit it, in some ways, when you think about the things I'm telling you, you might say, well, it sounds like old wine in a new bottle. We've seen this wine before. And I say, you know what? Yeah, a lot of this wine is familiar, but there is something about a new bottle, especially when, it's empirically supported. And maybe it's a snazzy looking bottle that people are attracted to. I don't think that there'd be a room full of people if I was just kind of pontificating about my ideas of dignity. It didn't say, well, and here are the 350 papers that, kind of support all of that work. Lastly, so, what is the essence of dignity? When I think about, the dictionary definition, which isn't bad, is, to be deserved of honor, respect, or esteem. That's pretty handy. But when you dig down in terms of the evidence, what you see is the things that make people feel dignity isn't the same for everyone. And again, if we went back to some of the previous slides, you'd see that the model of dignity includes different things for different people. There is one model, and as care providers, it beholds us to at least be aware of the things that might assault human dignity. For some, it's a very physical experience. Keep me pain-free, keep me clean, keep me warm, and my dignity is preserved. For others, it is much more, well, I mean, I'll be talking about later, it is about generativity, which is about legacy. You know, will my life have a ripple effect? Will I have made a difference for the fact that I was in this world at all? And for others, it really is a spiritual pathway. So that's the beginning of an answer that could be part of a separate conversation, and perhaps one we'll take up over coffee. Do we have? Yes, at the back, and then you.
Spoke about tone in the way we meet patients.
I'm sorry, can you say that again?
Spoke about tone in the way we meet people or patients. So I understand that piece of it. Would you also suggest that not, of course, in a one-time visit, but as a nurse, spending a lot of time with the patient, particularly in palliative care, should they be exploring the person's dignity and what they would feel, or what are they looking for in this relationship?
Good. So for those who didn't hear, the question is, at the bedside, I mean, should we be exploring someone, you know, sit down and say, so we're here to talk about your dignity. I need to find out about that. What matters? You know, the answer is I'm not sure of the language, because when we have, I mean, we started exploring dignity because, you know, there was this signal, you know, that came from the other side of the ocean that said, you know, this, when there's something happening here, it undermines a patient's desire to go on living. And then, you know, all of the evidence that I've shown you emerged from that. What I do think, and I feel, so, you know, sitting down and asking somebody about dignity, I mean, it's, the conversation is fraught from the outset because, well, what does that mean? And then you say, well, I don't know, what do you think it means? And, you know, there's this circular kind of thing that, but what we've discovered is that personhood, you know, being seen for who you are, everybody is on that page. I just gave a talk to some folks in India yesterday, a virtual talk. I don't move that quick. A virtual talk. And, you know, they were talking about, you know, the various cultural nuances and differences and, you know, family-centric. But at the end of the conversation, everybody agreed that, you know, each of us want to be seen and known as a human being. You know, we don't want to be known as the embodiment of our illness. We want to be known as that person with an illness. So I would say, rather than thinking about, well, I'm going to go back to the word and start talking about dignity, what I would go back to the word and say is, who is this person? And at least asking, what is it about who you are that you would like me to know? Because, you know, people have complex lives, people have secret lives, and don't necessarily want to be sharing that with everyone, or wouldn't want it known in a universal way. But what is it about you as a person that you think I ought to know so that I can kind of, you know, give you the best care? Those conversations, I mean, I'm seeing those happen in multiple places around the world, and uniformly what people say is, you know, it kind of changes things, and it works. The other thing is you end up hearing things from people that just change your perspective, you know, like that woman who said, I'm a residential school survivor. A woman that I looked after who said, well, if you want to know about me, what you need to understand at my age, my pending death isn't a tragedy. The fact that my son is dying in the hospital on the other side of the river, I am up at nights worrying, what's going to happen to my daughter-in-law? What's going to happen to my grandchildren? And another gentleman who said, what you need to know about me is at one time I was a chairman of a department of medicine. What I'm saying is you see that, you hear that, and I mean, it changes the way, it changes the emotional and spiritual chemistry. You know, I mean, I know that sounds kind of nebulous and vague, but it changes that chemistry. And that chemistry makes a difference. It makes a difference to the patient, it makes a difference to the family, and it makes a difference to the healthcare provider.
Oh, one final question.
Oh, I think this woman had her, I think you had her hand up first, and if there's another question, either we'll answer it or you and I will talk after privately, and I'll give you a really good answer.
I'll be quick. I will do my best. It's hard for me. Okay. Yes. Hi.
I'm sorry.
Hi.
Hi, how are you?
Good. I'm Vicki. I'm a palliative care nurse, and I do work in community home consult. And often, too often, I guess, but we have patients that will request medical assistance in dying, and of course we investigate the reasons behind and all of that sort of thing. But we do get people that say, I've lived my life and I'm at peace and I'm ready. And you know, there's one particular gentleman that I had. He was a fairly young man with head and neck cancer, was in a lot of pain, suicidal ideations when we got involved. It was, you know, many levels things weren't going well. But we did, and you know, Dr. Ritter, our team is great, an excellent job of getting his pain managed. He thanked us for giving him his life back.
Yep.
He was going out, he was traveling again, and it was at that point that he then decided that he was going to get medical assistance in dying.
Yep.
And when I spoke to him about it, it was like, you gave me my life back. I have my dignity back. I have autonomy again. I can do things. And I want to kind of end things on a high note. And I don't know if you've come across many situations like that. How do you feel that ties in? You know, like a lot of the people that you know, kind of study, they were having pain, depression. I mean, there could have been still aspects of that, of course, but have you seen much of that? Like, do you feel that some people have...
I've been at it for 35 years. I've seen a lot.
So, yeah, just your thoughts on that.
So, I mean, it's the opening of a huge conversation, and maybe we'll have time to talk a bit more about it after. What I would say is that people talk about dying with dignity as though dying with dignity is medical assistance in dying. What I say is that, well, that may be true for some and in some circumstances. I think what's important to understand is that dying with dignity is about so much more. I mean, dying with dignity is about attending to the comfort and mitigating the suffering of someone during the course of their illness. Dying with dignity is about being able to provide someone an opportunity to be in a place they want to be, with the people they want to be there. And dying with dignity is about treating people with dignity until they take their final breath. So it's a kind of a succinct answer to what is a huge question. I'm wondering if would everybody be okay with one more question, or is everybody dying to have lunch? One more? Okay. It's okay?
Yeah, I was just adding on to that. I'm a social worker. Been doing social work for 4 years, and elderly care for almost 1 year. And one of the things that keeps coming up when listening to dignity, or listening, we're thinking about, so think about burnout and the stress of working in chronic health, with chronic health, and how we can help a patient feel that feel respected and heard. But the other thing is, I think of us as healthcare workers and keeping our interest, I guess. It's like never allowing us to, keeping our own curiosity about developing a relationship with our patient can actually be the trigger to those conversations of finding out the essence of the person. So, because it is relationship, it is that intimacy that happens between the healthcare provider and the patient that I think is, kind of core, but it also can help us individually to continue our careers and doing the best possible care of the patient.
Yeah, no, wonderful comment. Again, as you're just sort of, many of you are just embarking on your careers in medicine, and there's this, and of course you do need to objectify and look at the various siloed areas of study that are on your plate. And along with that, unfortunately, can also be the consequence that you lose sight of the person, and people almost say that well, that's a way of kind of self-protection. We need to be protective so that we're not overwhelmed. And I guess what I would say is that when you think about compassion, it's not an option. Compassion, connectedness, it's part of the gig. But here's the thing. Think of it more like a dance. If you're so close that you're feeling hurt, that you're owning the suffering and you're feeling hurt by it, you're going to be overwhelmed and you're going to want to withdraw from that. But if you're so distant that you're completely oblivious to it, then you're unavailable to your patients. And all of the reasons that I've talked about, they're not going to trust you. I spoke to the medical students for their white coat ceremony, and one of the closing pieces of wisdom that I left them with is patients won't care what you know until they know that you care. And maybe that's not a good, maybe that's a reasonable note to end on. Okay, thank you all very much.